Welcome to PRISM Rounds, the audio journal club, where we break down one study at a time for ICU, ED, and pulmonary/critical care teams, including physicians, trainees, nurses, pharmacists, and respiratory therapists. Each episode is designed for busy clinicians who want to understand not only the headline result, but also the clinical question, study design, key findings, limitations, and bedside relevance. The goal is to make new evidence easier to digest and more useful for real-world practice. Whether you are on service preparing for rounds, teaching learners, or simply trying to stay current. I originally started making these episodes to support my own learning and review. I am sharing them publicly in case they are helpful to other clinicians and learners who are trying to keep up with the growing critical care and pulmonary literature. Everything you hear is for educational purposes only and should not be taken as medical advice. Clinical decisions should always be made in the context of the individual patient, local practice standards, and the judgment of the treating clinical team. This week we discuss the 2026 Blue Journal EIT-Vent trial, which asks whether electrical impedance tomography can help clinicians set PEEP more precisely in moderate to severe ARDS. The key issue is familiar at the bedside. Higher PEEP may recruit collapsed lung, but it may also overdistend already open lung or worsen hemodynamics. Overall, EIT-guided PEEP did not reduce mortality compared with the lower PEEP/FiO2 table, but there was an intriguing signal in patients with higher lung recruitability. This episode asks whether EIT is best used not as routine daily titration, but as a selective tool for precision ventilation.
So, picture this. It is 2 a.m., and you are standing at the bedside of a patient in the intensive care unit.
Right, the classic late-night scenario.
Exactly. And this patient has severe ARDS, acute respiratory distress syndrome, so their lungs are incredibly heterogeneous.
Which is such a massive challenge, because of gravity and fluid buildup. The dependent areas, like the parts of the lung resting against the bed, are just completely collapsed. They are heavy and wet.
Yeah, but then, meanwhile, the upper ventral parts of the lung might actually be perfectly open.
Right.
And as the attending, you have to adjust the mechanical ventilator's pressure, specifically the PEEP, the positive and expiratory pressure.
Right, which is always this really difficult balancing act.
Yeah, because you turn the PEEP up to pop open those collapsed areas, but in doing so, you risk dangerously overstretching the healthy parts that are already open.
It is the fundamental mechanical dilemma we face in critical care. I mean, we really want to recruit that collapsed lung tissue so oxygen can reach the blood. But we also know that applying too much pressure to those delicate, already aerated alveoli, well, it causes irreversible damage. You get overdistension.
And that is exactly what we are getting into today. In this deep dive, we are looking at whether a specific piece of advanced imaging technology can finally, give us the map we need to navigate that dilemma.
Yeah, it is a fascinating topic.
We are looking closely at the 2026 EIT-Vent randomized clinical trial, which was published by Yuan and colleagues in the American Journal of Respiratory and Critical Care Medicine.
A highly anticipated trial, honestly.
Oh, absolutely. And alongside the trial itself, we are also going to explore the accompanying editorial by Tobias Bacher and Eduardo Costa.
Which asks a really profound question about all this. Like, can our obsession with getting perfect physiological data actually cross a line into causing active harm?
Yeah, it is a brilliant point. But before we get to the trial results, I think we need to explain what is actually happening physically inside an ARDS lung.
For sure.
Yeah.
Because we need to understand why PEEP is just such a difficult tool to use safely. When a patient develops severe ARDS, the lung doesn't just uniformly stiffen up. Because of the flooding and the inflammation, the actual usable aerated part of the lung shrinks dramatically.
Right, which is what we call the baby lung concept, right?
Exactly, the baby lung. So when the ventilator pushes a normal breath of air in, that air doesn't distribute evenly at all.
It takes the path of least resistance.
Right. It preferentially rushes straight into the healthy open parts because those collapsed fluid-filled parts, they just offer way too much resistance.
So the healthy tissue ends up taking the full blunt force of the ventilator.
Which is terrifying mechanically.
It really is. It is like Imagine trying to inflate a damaged, complex pneumatic system where some valves are basically rusted shut and other valves are made of this paper-thin membrane.
That is a great way to picture it.
You are trying to find the exact right system pressure, the perfect PEEP that has just enough force to pry open the rusted valves, but, isn't so high that it completely blows out the fragile membranes.
And that is exactly why PEEP is dangerous. I mean, PEEP is continuous pressure, keeping the airways stented open at the end of a breath. We need it to prevent the alveoli from collapsing, which is vital for oxygenation.
But if you apply too much...
Yeah, if you apply too much PEEP, you cause severe overdistension in those fragile membranes.
Yeah.
The alveoli just ballooned outward, and as they overexpand, they actually physically squish the tiny blood vessels, the capillaries that wrap around them.
And that creates a massive downstream problem for the heart.
Oh, massive.
Because if you squash all the capillaries in the lung, you are increasing the pulmonary vascular resistance.
Right, so the right ventricle of the heart now has to pump blood against what is basically a brick wall.
Yeah, so you might succeed in getting the lungs open, but you trigger acute right heart failure in the process, which is obviously not the goal.
Definitely not. And historically, clinicians just haven't had a real-time window into the chest to see this localized collapse and overdistension actually happening.
Right, we are essentially flying blind. I mean, we rely on indirect global clues. We look at systemic oxygenation, or we measure the plantar pressure, or calculate the driving pressure and the overall compliance of the lung.
But those are global numbers. They only tell you about the whole lung on average.
Exactly.
So you can easily have a patient whose global numbers look perfectly acceptable.
Yeah.
But regionally, their lower lobes are collapsing with every single breath while their upper lobes are being massively overdistended.
And this exact blind spot is what EIT was built to solve. Electrical impedance tomography.
Yes, the promise of EIT.
Right. So to understand why the critical care community was so excited about this trial, we have to talk about the physics of EIT. Basically, it involves placing a non-invasive belt with a bunch of electrodes around the patient's chest.
Right, and those electrodes send these tiny, imperceptible electrical currents through the thorax.
Right, and it works because different tissues conduct electricity differently, like blood and muscle conduct electricity pretty well. But air is an insulator.
It resists the electrical current.
Exactly. So as the patient breathes in, air fills the lungs, and the electrical resistance, the impedance, goes up. And then when they breathe out, it goes down.
And the monitor at the bedside is taking thousands of these measurements in real time, translating them into this dynamic, moving heat map right on the screen.
Yeah, it is incredible to watch. You can actually see the breath move into the different quadrants of the chest.
You really can. And for years, all the physiological studies told us that EIT provides this incredibly detailed map. It clearly shows you if the dorsal regions are staying collapsed or if the ventral regions are overdistending.
So the community reasonably assumed, hey, if we use this perfect map to guide our PEEP settings, we can precisely balance the lung, prevent ventilator-induced lung injury, and just save more lives.
Right, it made perfect physiological sense. But up until now, we only really had physiological data. We didn't actually know if treating the EIT screen translated to a true survival benefit for the human being in the bed.
And that is what the EITVent trial set out to prove. So they took 190 adult patients with moderate to severe ARDS across 5 different ICUs in China, and they randomized them into 2 groups.
Okay, so what was the control group doing?
The control group just had their PEEP adjusted using a standard lower PEEP and FiO2 table, which, basically just matches the pressure to whatever the patient's oxygen requirements are.
Standard of care.
Right. And then the intervention group received the high-tech EIT-guided PEEP strategy. But, and this is really important, we need to look at the mechanics of this intervention. It wasn't just, putting the belt on and looking at the screen.
No, the protocol was actually incredibly aggressive. It required a daily decremental PEEP trial.
Right. In a decremental PEEP trial, it sounds very clean and clinical, but what it actually puts the patient's body through is intense.
Extremely intense.
First, the team does a recruitment maneuver. So they apply a deep, sustained, high-pressure breath to forcefully push open as much collapsed tissue as physically possible. Then they set the PEEP super high, up to 20 centimeters of water, and from that baseline, they step the PEEP down by 2 centimeters every few minutes, bringing it all the way down to 0.
And they had to do this step-down maneuver because the EIT algorithm needs to calculate the changes in impedance at every single pressure level.
Right. As the pressure drops, the screen calculates exactly how much dependent lung is collapsing and how much ventral lung is recovering from overdistension.
And the software basically plots these two intersecting curves, and the goal is to find what they call the crossing point.
The crossing point.
Yeah, it is the exact mathematical pressure where estimated collapse and estimated overdistension are perfectly balanced. And once they find it, they lock the ventilator in at that exact PEEP.
I mean, it sounds like an engineer's dream, right? You stress test the pneumatic system, map the resistance, find the mathematical point of perfect balance, and you set the dial.
It really does. You have a control group getting a generic oxygen table and an intervention group getting this incredibly precise, custom-tailored, image-guided setting.
And yet, the trial was stopped early for futility.
Yeah, stopped early.
The data monitoring committee basically looked at the numbers and said there was virtually zero chance the EIT strategy was going to show a benefit.
Which is wild.
It is. Overall, the EIT-guided PEEP did not significantly reduce 28-day mortality. In the EIT group, mortality was 55.9%. And in the standard control group, it was 52.6%.
Wow.
Yeah, the hazard ratio was 0.96 with a 95% confidence interval of 0.65 to 1.41.
So statistically, basically a coin toss.
Exactly. No significant mortality benefit at all. And no difference in ventilator-free days, ICU length of stay, or barotrauma either.
But wait, if the EIT screen showed the exact mathematical crossing point where everything is perfectly balanced, why didn't these patients do better? I mean, it's just basic mechanics.
Well, we have to look at what the EIT algorithm actually instructed the clinicians to do in the end. When you look at the final settings, the actual difference in the applied PEEP between the two groups was tiny.
How tiny?
Over the first week, the average PEEP in the EIT group was 8.7 centimeters of water. And in the standard group, it was 8.5.
Are you kidding?
No. So the teams put these critically ill patients through this massive exhaustive stress test, dropping their pressures from 20 down to 0, just to end up setting the dial like a fraction of a centimeter away from where the low-tech oxygen table would have put it anyway.
Oh, wow. I mean, when both groups are already receiving excellent fundamental care,
Yeah.
because they were both getting lung-protective low tidal volumes, right?
Right.
And they had high rates of prone positioning in both groups.
Yeah, they did.
So if you are already doing the big things right, a difference of 0.2 centimeters of water in PEEP is just not going to change mortality. Prone positioning alone physically redistributes the fluid weight and improves ventilation perfusion matching so well.
Exactly. The microscopic adjustments offer diminishing returns.
Yeah.
But, and this is where it gets really interesting, the data gets much more complicated when you look at the subgroups.
Ah, yes, the recruitability subgroup.
Right. The researchers didn't just measure overall mortality. They pre-planned to look at how patients responded based on their lung recruitability, which they tested using the RI ratio.
Recruitment to inflation ratio.
Exactly. And this is a brilliant way to quantify the mechanical nature of a patient's ARDS.
So how did they measure it?
Well, before the main trial intervention started, they did a single breath maneuver. They stabilized the patient's PEEP at 15 centimeters of water and then rapidly dropped it down to 5.
Okay, so you drop the pressure from 15 to 5 and the lung deflates.
Right. And the ventilator measures the exact volume of air that is exhaled.
And because they already know the baseline compliance like, the stretchiness of the lung at a lower pressure, they can compare the actual exhaled volume to what they'd expect.
Exactly. If the volume that comes out is significantly larger than expected, it means that extra air was sitting in lung units that were only being stented open by that higher pressure of 15.
Right, so that extra volume is the recruited volume.
Yeah, and by dividing that recruited volume by the pressure change, you get the RI ratio.
Okay, so what were the cutoffs?
A high recruiter was defined as having an RI ratio greater than or equal to 0.5.
Meaning their lungs are responsive, you apply pressure, and those rusted valves actually pop open and participate in gas exchange.
Exactly. But a low recruiter with an RI ratio below 0.5 has a lung that is stiff, fibrotic, or just deeply consolidated. You can apply all the pressure you want and it just refuses to open.
Okay, so what happened when they split the trial data by this RI ratio?
The results were super polarized. In the high recruiters, EIT worked beautifully.
Really?
Yeah, mortality dropped from 60.0% in the control group down to 35.6% in the EIT group. The hazard ratio was 0.49.
That is a massive signal.
It is. For those specific patients, the EIT screen correctly identified that they needed slightly higher PEEP, about 2 centimeters of water more, and that precise extra pressure led to better lung compliance and lower driving pressures.
Which is completely physiologically plausible.
Yeah.
I mean, if the lung tissue is actually capable of opening, having precise EIT guidance gives you the confidence to turn the pressure up safely. It stops those dependent regions from cyclically collapsing and reopening, which we know causes shear stress injury.
But, and this is a huge but, we have to look at the low recruiters. The patients with the stiff, consolidated lungs.
Right, the ones who don't respond to pressure.
In that group, the EIT strategy showed a distinct trend toward worse outcomes, higher mortality.
Wait, really? But if the algorithm ultimately just told the clinicians to set the PEEP in basically the same spot as the control group, why would the EIT group actively do worse? I mean, the monitor itself is just a passive band around the chest. It doesn't physically hurt them.
Right. And that brings us to the central thesis of the editorial by Beecher and Costa. It wasn't the monitor. It was the clinical bundle of care required to make the monitor work.
How much titration is too much?
Exactly. They argue that you can't just evaluate the EIT device in isolation. You have to look at the physiological toll of the decremental PEEP trial itself.
Which was happening every single day.
Every day. To get that perfect crossing point graph on the screen, the data has to be absolutely pristine. The patient cannot be taking spontaneous breaths or fighting the ventilator at all.
Because any extra movement completely skews the impedance mapping.
Yep. So to achieve that pristine data, the protocol required deep sedation and heavy chemical paralysis. Neuromuscular blockade was used in 65.6% of the EIT group, compared to only 51.5% in the control group.
Wow. And obviously, increasing sedation in paralytics carries its own massive ICU morbidity.
Right. But the physical toll on the unrecruitable lung is even worse. Remember, every day for 7 days, they get a massive recruitment maneuver, and then their PEEP drops from 20 to 0.
Right. And if you have a low recruiter with a stiff lung, forcing the pressure up to 20 doesn't open the collapsed areas. It just forces all that excessive air into the small percentage of ventral lung that is already open.
Exactly. You are subjecting the healthy tissue to transient, severe overdistension, stretching those membranes to the breaking point.
Which causes massive spikes in pulmonary vascular resistance and acutely stresses the right ventricle.
And then minutes later, you drop the pressure all the way down to 0, so whatever marginal recruitment they might have had instantly collapses again.
You are basically subjecting these fragile lungs to a daily physiological earthquake. Massive pressure swings on lungs that lack the elasticity to handle it.
Right. And as Bisher and Costa point out, lung recovery is slow. Subjecting an inflamed lung to extreme daily pressure swings just to draw a graph on a screen, it is immense physiological stress.
So the technology didn't fail them. The daily ritual of testing them failed them.
Exactly. We treated the monitor, not the patient. It is honestly like the observer effect in physics.
Oh, right, where the simple act of measuring a particle alters its trajectory.
Yeah, forcing a damaged lung through extreme pressure swings just to measure its mechanics ends up damaging the very tissue we are trying to heal.
That is a profound way to look at it. So how do we bring this to the bedside? I mean, clearly, routine, daily EIT-guided titration for every moderate to severe ARDS patient is not the answer.
No, definitely not. But we did see that provocative survival signal in the highly recruitable subgroup, so we shouldn't just abandon the technology.
No, EIC is still incredibly valuable, but its future is as a precision monitor, not a blunt daily titration tool. We need a phenotype-informed workflow.
Right. So instead of putting every patient through a daily 20 to 0 pressure drop, you do one careful initial assessment of recruitability using the RI ratio.
You figure out if you are dealing with a high recruiter or a low recruiter.
Exactly. And once you have that baseline phenotype, you use the EIT for targeted, smaller adjustments within a plausible range. If the lung is stiff, you don't need to drop the pressure to 0 just to confirm that it hates being at 0.
Exactly. You use it for difficult PEEP decisions, or to assess persistent dorsal collapse, or to monitor the regional response when you prone the patient.
Right. Selective use. And above all, this trial really reinforces that advanced monitors do not replace fundamental critical care.
No, they definitely don't. We have to maintain low tidal volume ventilation, monitor driving pressure and mechanical power, prone early, and watch hemodynamics.
Speaking of hemodynamics, there is a specific line from our sources today that perfectly captures the danger of getting tunnel vision with a new screen. They write, quote, "A beautiful saturation with an angry right ventricle is not victory."
That is such a crucial reminder. It is the classic trap of the modern ICU. You see a blood oxygen saturation of 100%, and the EIT screen looks perfectly balanced. But if you achieve that by cranking the PEEP so high that the overdistended alveoli are crushing the capillary beds.
Right, and causing the right side of the heart to dilate and fail.
Yeah, you haven't healed the patient. You have just traded respiratory failure for cardiovascular failure.
Which brings us to the ultimate takeaway rule for bedside practitioners from the editorial. They state, quote, "Don't throw away the PEEP table, don't worship the EIT screen, and don't forget the patient."
I love that. The standard tables provide a safe foundation. The EIT offers a powerful window when we need it, but the patient in the bed is the only metric that truly matters.
Absolutely, because if the patient requires heavy chemical paralysis and daily extreme pressure swings, just so we can fill out a data chart with a perfect crossing point, we are treating the monitor.
We really are.
It really leaves you with a provocative thought about modern medicine. We live in this era of continuous high-definition data monitoring.
Right, from our watches to the ICU monitors.
Exactly. We have devices mapping every electrical impulse. But the EITVent trial shows us the medical observer effect in action. Sometimes the extreme lengths we go to just to measure a physiological state actually ends up harming the body we are trying to heal.
It forces us to ask, when does the pursuit of perfect data become the enemy of good healing?
And true expertise isn't just having the capacity to extract the most precise data. It is knowing exactly what to do with that data, and crucially, knowing when the physical cost of getting the map outweighs the benefit. Thank you for joining us on this deep dive.
Thank you for spending your time with PRISM Rounds. If this episode helped you think through the paper or offered something practical for the bedside, I'd be grateful if you'd like, follow/subscribe, and share it with a colleague. It's the simplest way to help this resource reach other busy clinicians and learners. I'm also trying to make the podcast better with every episode. Please leave a comment with what you found most useful, what felt unclear or too long, and what topics or papers you'd like covered next. If there's anything I can do to improve pacing, structure, level of detail, or audio quality, I genuinely welcome the feedback. Thanks again for listening, and take care. Educational use only. This is not medical advice.